Hi, everybody. Welcome to New Frontiers in Functional Medicine, where we are interviewing the best minds in functional medicine. And of course, today is no exception. We're going to be doing a dive into infertility, into PCOS. It will be very solution driven. We're going to be talking about a pretty exciting lab test, actually, we're adopting in our clinic. And I'm just excited to introduce it to you. We'll also dive into a little bit of the problem of infertility that we're seeing globally. But before we do all that, let me introduce you to my interviewee today. Her name is Dr. Tara Harding. She's a distinguished family nurse practitioner, fertility coach, and medical advisor for Mira. She's known globally for her expertise in women's health and infertility and combating medical gaslighting, gaining recognition through her educational content on TikTok with over 15 million views per video. That's so crazy to me, Tara. And her widely downloaded podcast, Helpful Hints. Dr. Tara has also been featured in notable publications like BuzzFeed and Today's Parent. Her unique blend of professional knowledge and personal experience, coupled with her commitment to empowering patients, has made her a guiding force in the healthcare community, especially in navigating personal health challenges and providing tailored women's health and fertility solutions. Dr. Harding, welcome to New Frontiers.
Hey, thanks for having me.
Listen, I just want to ask you one prelim question. What's your story? I mean, like what's your own personal experience that has made you so passionate about this this topic?
Yeah, like so many individuals out there doing great things in women's health and fertility and just the medical field in general. There's usually a little bit of a personal story attached to it. And
Yeah.
mine was going through infertility as a medical provider. I actually was living in rural North Dakota, so that put some barriers to a lot of things too. But just as a provider moving through the system, I was just caught off guard in so many areas. And there were so many things done wrong
Yeah.
that, like, when I came out on the other end, which I did have to go through IVF, but I was like, what just happened? Like, I remember holding our 6-week-old son, and I was just like, this is ridiculous, from cost to process to the mental health. Just why? I had no answer. I had unexplained infertility in the beginning, and I was not okay with that as a medical provider. I'm like, you can't just be like, oh, sorry, I'm not sure here. Carry on. Like, we're just gonna keep pushing forward. I feel like I was just kind of getting pushed forward with things and no answer, and that not knowing drove me nuts. And so it eventually transformed into, I started with a nonprofit. So I started the first and only nonprofit in North Dakota and South Dakota for those with infertility. There was just no support. And then I started driving legislation to advocate for insurance coverage for the disease, which I'm still 6 years later working on that, but we're making big progress with that. And then it, of course, led into me being a fertility coach first. Like, being an entrepreneur in the medical field is just a whole like thing they don't ever teach you anything about. And then that grew into this telemedicine in 3 states. And now I'm brick and mortar offering IUI services. So it's really just grown, and all from my own story and my own working as a provider. How was I treated, and how would I have liked to be treated, and how should women and couples, how should really anyone just in healthcare be treated the moment they walk in your office through their whole process, and believed, and again, mental health always being forefront of things too. Um, and that came from, and I was met by a provider saying, well, when you're crazy enough, let me know and we'll move on to the next steps. And I was just like, I'm already in counseling. Yeah, after
Brutal.
miscarriages and going
Mm.
through things, it's like, ma'am, I'm sorry, but I'm already, like, you don't say that to people, but I'm already in counseling, little did you know. So it's all really just from, again, my personal experience, and then having students and really wanting them to follow me and be like, here's how you actually should talk to your patients, and here's how their options should look, and letting the patient drive their entire process from start to ending.
Wow, that is such a powerful story. What a powerful testament.
I later found out she was going through her own stuff too, and I'm just like, okay, I get that, but at the same time, I'm just like, we all go through stuff every day. We can't let that bleed out to our patients. Like,
Yeah.
you have to just watch our words. And that's really what I try to teach
Yeah.
students too, is how to keep your personal bias or things out of it too, and let that patient just, again, drive every conversation. So it's ironic
Yeah.
that you had that too, because looking back, I had found that out later as well. It's kind of crazy.
Well, yeah, we're the safe space. We're
Yeah,
we have the opportunity to be the safe space. We have the
yeah,
opportunity. And I think we have, with, to your point, we absolutely have the responsibility to extend that safe space. I mean, that is, I think, for me, the fundamental joy of practicing. I mean, of course, being a functional medicine provider and being very solutions driven and being able to really walk with people in their healthcare journey, like every aspect of it is rewarding, but being able to actually extend somebody the opportunity to have a safe space, I think, is probably the most powerful thing, we're able to do.
absolutely.
Yeah.
Absolutely. Yep.
Wow. Okay. I did not quite expect us to start in that very powerful and personal way.
Yeah.
Wow. Okay. Well, thanks for your courage. Really,
Oh,
thank you
you're
for what you're
welcome.
doing. Wow, it's incredible.
Thank you.
Incredible. Okay, so we started on the infertility conversation, or this is our topic today. And again, as I said earlier, we're going to be very solutions driven. This is a conversation mostly for clinicians, but there's plenty of savvy, non-clinicians listening. I, we're in a infertility epidemic. So if you can speak a little bit to that, like what we know as contributing, um, and then we'll move into what we do about it. But if you can give me contributors, and maybe if you've got epidemiological data, I would, it's not, I
Yeah,
don't want to say that I would love to know, because it's actually pretty disheartening, but
it is.
yeah, let's talk about that.
Yeah, so we know that infertility rates across the world, this number is 1 in 5. And I'm looking back at when I started my nonprofit, it was 1 in 8. There was a study done about 2 years into that. So around 2020, 2021, they kind of changed how they um did the data on that. And we already knew it was 1 in 6. And now worldwide, we know it's 1 in 5. And we know that like 55% of those going through this, it's more stressful than unemployment. We have found it to be a leading cause of trauma in women. We know that 73% of people experiencing infertility report it impacts their work. That's like huge. And we know from some other data too that it's actually comparable when you go through like infertility to like the grief and the anxiety and depression and all that of losing a parent, or it's just as stressful as cancer. So we have all of these like comparisons that this disease is, and yet it's things like insurance saying that it's not medically necessary, so we're not going to cover it. And then you have individuals being stuck with high cost, and there's no affordable solutions or very minimal affordable solutions,
Yeah.
and they're just kind of having to pick. Um, I also work with a lot of like fertility preservation patients too, and they're in that like time crunch of like, do I, teens, 20s, 30s, maybe they don't even have a partner or a significant other yet, and they have to decide, am I going to preserve my fertility or quickly move forward with treatment, and due to cost. And so cost is always such a number one issue to the word infertility as well. And there's only like 500 infertility clinics that exist nationwide. Lab tests are expensive. You have to have these in person, appointments for things, or every clinic kind of wants to have you come there for stuff like that. 33% of like first round of IVF cycles are unsuccessful, and those are 19 to 20,000 a pop too. So these are not like little things that we kind of, when you get, stuck with that diagnosis, there's so much that goes into it. It's not like, okay, go see your local provider down the street and see what they got to say. There's just so much that goes into it, on top of like, why do you have infertility? Ooh, is it one of you, both of you? The man gets forgot so often too. It's just, ugh,
Yeah.
that's a whole like rant I could go on too. But um, it's just it's so, there's just so much that goes into that, and that why.
Well, and I mean, just to bring the the men into the conversation for a minute. I mean, well, first of all, let me just point out that, you know, you launched your nonprofit, you said in the beginning 6 years ago, and already our numbers are worsening in fertility just in your short jog. And by the way, folks, sidebar, we'll link to these resources from Dr. Harding. They're awesome. And maybe we'll link to your crazy popular TikTok. I'm
My
never
fun
on TikTok, but
I'm
I'm
wearing
super
these
curious
glasses
about
in
it.
it. It's you have to go watch. The ones that went, they all were me doing this. So I'll just do that right now too to trigger everyone to come over
To
take a look.
recognize. Yeah. Um, so yeah, so the stats are just getting
Worse.
worse at a pretty breakneck pace. And yeah, I know that the sperm count has, you know, meteorically declined, probably really in lockstep with what we're seeing in women. But you know, what do you think? Like, what can you
Yeah.
put your finger on as causal to both? I mean, what are your thoughts? What have you read? What are you
Yeah.
seeing in
So
practice?
a lot of it is the lack of understanding basic disease processes and how to diagnose them from the medical community. You know, PCOS missed all the time, endometriosis, male factor infertility, thyroid conditions, just straight up missed. I don't know if it's like they're not comfortable giving it. It's almost like they feel like they're going to give them a cancer diagnosis or something if they say you have PCOS, and it's like blazing obvious. It's not even like anything. I don't do anything majorly different than should be done to diagnose some of the stuff initially. And it's like, did you look at the patient? You know, basic understanding of the disease, but environmental for sure goes into this too. You know, and I will even say I have seen viral illnesses and COVID and things like that truly impacting sperm, or long COVID impacting a lot of my male patients too, and having to really work on that when it comes to male factor. Stress. Holy moly, we are just a stressed out world. And it just gets like foo-fooed and dismissed instead of like addressing cortisol and really working with patients to figure out how they can best work that into their life. They just go, you know, change this, do this, whatever, or it's not even an issue. They think the stuff that I use to treat cortisol is like foo-foo. Really just this is so basic, but I don't know if healthcare providers understand ovulation and a menstrual cycle and a fertility cycle. Like, if they really took the time and looked at patients' data that they have right there on their smartphones nowadays, you would see right away this individual has a hormone imbalance. This individual is not ovulating. This individual has something going on, and they're just like, nope, here's your IUI, or, you know, after so many IUIs, here's your IVF, you know, carry on. They're just getting kind of brushed through the system and not working with, you know, nutrition and movement and sleep. People need to sleep. Everyone, I don't know how many times I put on a patient's chart in a week: insomnia, weight gain, you know, fatigue, things that are just really looking at their external environment and family history. So one of the first things I do when I talk to my patients, very first day, yes, there's like family history, but when I'm talking about a menstrual cycle, I try to make it a light conversation. You know, if you know, can you share with me, like at the holidays, are we having conversations with mom, aunts, sisters, cousins about our hormones and hysterectomies? And I try to like make it a light conversation, but I can ping, you know, endo and PCOS from a mile away within the first 10 minutes of talking to them by looking at their high school period intake. So tell me about your period. How old were you when it started? What was it like when it started? Were you missing school? Why did you get put on birth control? That's like a dead giveaway too for a lot of stuff. When I'm asking like why they got put on that, and really looking at the historical side and family genetic side of that too, as
All right,
well as being a possible.
I want you to just speak to some of those really obvious clues, and if you can distinguish PCOS from endometriosis early, like what are some of those clues? I mean, you're going to have to color this in. People are
Yeah,
asking.
so the clues are acne. If someone's like, I got put on it for acne, I was always the female who was a little bit overweight. I was in 6 sports and I couldn't lose weight and I was gaining weight in high school already. Or if they were the female who, went to college and again, whether they were athletic or not, and they gained weight out of nowhere, I'm thinking PCOS. If they have a mom or a sibling with a hysterectomy, endometriosis and adenomyosis is at the forefront of my mind. There's data out there now too showing any young female with a painful period is endometriosis until proven otherwise. And the earlier we can catch that, man, like things can be significantly different for just her going forward and not being placed on birth control. If they're placed on birth control for heavy, painful periods, heavy, bleeding all the time, I'm missing school because of it, endometriosis. And to just dispel any myths right off the bat, you can most certainly have PCOS and endometriosis and or thyroid disorder. Going on at the same time. It's just that's been kind of brought up like, can I really have both of them? And never dismiss a female who comes to you, even if they're, and we're going to focus, on fertility and stuff, but if they're coming to you in their 40s and 50s and they've had chronic pain, my other new finding in my office, I feel every female with fibromyalgia needs to be talked to and looked at for endometriosis being the cause of that with inflammatory lesions, throughout. Fatigue can go both ways. I find fatigue it can be PCOS, insulin resistance. Everyone who's fatigued and having those daytime fatigue and or afternoon crashes or feeling crappy after they eat, insulin resistant, every single one of them.
Yeah.
This weight gain, libido change, hair loss, making sure we're checking for iron deficiency anemia and looking at all their stores. It all goes into that fertility picture too. But to not don't be scared to give someone PCOS whether they have Hirsutism or not. Like, don't be looking for just an outside appearance is probably my other thing I like to always share. A lot of women, you can look at them as I'm air quoting and be like, oh, they look like PCOS. But then you have your really lean athletic female who is not gaining weight and she could eat a whole, burger times 5 in a day and she's not going to gain weight, but she has no libido. Her progesterone, when you're looking at her charts and stuff, is really off and things like that too. Weight isn't always the indicator of that of PCOS too. They might not always have the look to them, but looking at their data, and we'll talk about this later too, but really looking at their hormones is going to really help navigate you. That estrogen, is it high all the time? What's their progesterone doing? That kind of thing too.
And I mean, I'm just curious, in your experience, how often are you seeing cysts in PCOS?
I'm so happy you brought that up. How could I forget this?
Cut to that.
Ride on. You don't need an ultrasound. I don't know the last time I ordered an ultrasound in my practice. Here's the a fun story about when I did order one. If they can time it specifically, usually around ovulation is where you're going to see someone with actual cysts, going on happen. You can time it to this. Oh yeah, it's usually around this time of the month. I have this pelvic pain, one-sided, both-sided, etc. Time it towards that. I had caught a teenager and she liked to ride horse. And she's like, it seems like only certain times when I ride. And we really took it next level. And I had her time it out. We had her come in specifically when she was feeling it. And that's how we caught it. But I don't know the last time I even ordered one. You do not need that. And I'm actually using AMH levels now. So AMH 4 or higher, 3.7 I did use the other day, 4 or higher PCOS, and you can pair that, of course, with your DHEAS and testosterone, but to just really, that's a new actual guideline that came out is we can use AMH levels now too. And that's been super fun because it's obvious all the time. It's a great marker to use that I've kind of flipped over to adding into their lab work along with all the other, insulin, lipids, and all the other hormones that I already was doing as AMH levels. But Yeah, not very often will I catch a cyst being the like, there it is, gonna diagnose it now. Now people are coming to me because they had ultrasounds that did not show a cyst and they still have PCOS.
Yeah,
So
of course. Yeah. Mhm.
it's yeah, I'm glad you brought that up.
Well, and AMH, actually, let me just have you define some terms. You can define that one just for any listener who's not in clinical medicine, IUI, IVF.
Yeah, AMH is anti-Müllerian hormone. IUI is intrauterine insemination, which is typically I should say, oral medications are usually used first for a time cycle for conception if you're going to roll into like infertility treatments. And then is that intrauterine insemination or IUI, where that sperm is washed, and there's various different methods of doing that. And then the female has her cycle timed and possibly more than likely a trigger shot given so we know the exact hour that she's ovulating to time that IUI. And then IVF is in vitro fertilization. And then, of course, that's taking the actual sperm, perfect sperm, injecting it into the egg in a timed process as well. But you're taking multiple eggs and multiple sperm and creating that embryo outside. And then many nowadays are doing the genetic testing and freezing and all of that process too that goes along with IVF. And you can also have, egg donor, sperm donor, embryo donor, and then surrogacy, of course, goes along with all of that too.
What's the age range that you're working with in your population? Are you working with pretty young women dealing with PCOS and then you go on into fertility work? Just out of curiosity.
I would have said yes about 2 years ago, but now I'm working with young teens. I'd say 12 is probably the youngest so far, where we're talking about period care, all the way up to 63, 65-year-old women. I'm starting to, of course, go into the perimenopause, menopause, but the endometriosis in the 50, 40-year-old women too is very
Wow.
significant nowadays. And they might even have had a hysterectomy and they're still having ongoing symptoms because that hysterectomy takes care of adenomyosis, where those growths are on the muscular part and the actual uterus itself, but no one took care of the lesions of actual endometriosis that live everywhere throughout the body, essentially, but in those areas as well, causing chronic pain, chronic fatigue, mental health. Oh, that's a whole thing too that goes along with all of these, with PCOS, endometriosis and everything, and infertility in general. But a lot of that, when you resolve root cause issues and the cause of everything, you can see great improvement in everything.
Oh,
But it's
God.
kind of grown. My age range has grown and changed and shifted
As
because
the
women.
issues evolve, right?
Yeah,
And the
exactly.
time they present, is probably changing in a somewhat of a disturbing way. So like precocious
Yes.
puberty and then sort of profound hormonal imbalances
Yes.
extending out much further.
And women being told nothing's wrong with them, that there is nothing going on with them, and they continue for years. I'm usually probably anywhere from the third to eighth provider, which is
Uh,
really a challenge in itself sometimes too. Because like, well, what makes you any different? I'm a nurse practitioner, I'm not a naturopathic doctor. So they like, you take insurance and you're a nurse practitioner. Surely you're just like everybody else we saw. And really, I have that nice blend of integrative and so I'm like, no, I'm different, you're safe here. And the first visit, they see that right away. But I had a patient, she was a third grader and got her period. It's just like, yeah, mind boggling. And it's like, how did all these providers miss that? There's such obvious stuff going on here,
yeah.
from a history standpoint.
Well, let me just ask you this because people are thinking about it, including me. I've got a lot of questions actually, but um, so standard American diet, crappy diet, pesticides, organopesticides, metallotoxins, mercury, lead, et cetera. You mentioned stress, you mentioned sleep. Um, so these exposures, like just all of this, I know it's not that you're an in the trenches clinician working with patients. I get that that's your vantage point, but any, any thoughts on this environmental piece? Oh, and you mentioned viruses, you mentioned COVID, but any thoughts on this and just, the presentations that you're seeing and the change in the epidemiological data, like earlier onset, continuing later on in life, et cetera?
Yeah, I think it's hard to dismiss that at this point, whether people want to acknowledge it or not. I think you can see it, and you can see that also in the decline in population rates. I think there's been
Sure.
some data that's come out on that too. This is general conception and population in this state's down and the country's down compared to this country, and you can just see all that. And when you look at how other countries, how they eat in general, their lifestyle, their environment, their day to day from wake to sleep, just how different that is from America. It's hard to deny the data that's there with that. So we are, in my practice, and I just think everyone should be really incorporating approaching things and changes and acknowledging that, because it's obvious, and there is, stuff of course to back that as well. But you can't be like, here, let's just, treat this arm. I say this a lot too, like your head's connected to your chest, is connected to your arms, is connected to your uterus. If you have joint pain in your knees and they're red and inflamed, it's not bypassing your uterus or your ovaries or your testicles. Like, hello, that's inflammation in your entire body. You need to be addressing that. Or you can't expect, if you're eating this, lifestyle or way, or alcohol, tobacco. Oh my goodness. My men, absolutely, I will not do an IUI or any treatment if they are nicotine. If they're on nicotine of any sort, vapes, anything, we cannot be having that, because it is huge impact to sperm. And I've seen that because I will put them on, the enclomiphene or, medications to try and override that. And I cannot get it budge for many of them, or it's very slow to budge. And it's like, you've got to change your lifestyle in your environment and what you're exposed to on a day-to-day, rigmarole too, to have that adequate fertility goal.
Yeah. Yeah. What about like antecedent variables? You did talk about genetics and you get a really careful family history. What about like maybe early exposure to antibiotics or chronic exposure, like, or, medications or, I don't know, a lot of allergies or other
Concussions.
illness. Yeah. Oh,
Yeah,
concussion.
concussions. Yeah, I started asking a lot about concussions, and so I'm seeing a lot of elevated prolactin levels in males, and that impacting sperm. I think
Of
I'll use
course.
the male example a lot, because again, oh, his sperm was fine. There's only just a little bit off, or just a few things were off, but they weren't worried about it. And I'm like, okay, no. And I do the same, take it from the top for my men too. But I am asking, men, women too, concussion histories, and that significantly changes cortisol as well. I do ask, I know a lot of my naturopathic crew, um, goes more into that antibiotic, style of it too. But I think if I ask about gut health, and so I'm asking about nausea, heartburn, indigestion, bloating, diarrhea, I'm going through the symptoms. And if they're, sparking something in me, I'm all about team building. So I'm not like, I'm going to be the one-stop shop. And I just think it's almost like dangerous medicine sometimes, if, providers think they can do it all. It is, hey, let's grow your team. Let's get you into acupuncture. Let's get you in and get some gut health testing done, because it's significantly important for your fertility. I believe that. I just might not be the one to be running all the tests
Sure.
on them. I am
Yeah.
growing my practice to that, but I'm not quite there yet. But I 100% ask about, any recent antibiotic use, or did your symptoms start after, you took an antibiotic? Or even if it was like, oh yeah, I did fertility treatments and they put me on antibiotics, that kind of thing too. It's just kind of like crazy, like what I'm kind of finding too by going down that road. There's a common variable there for sure.
Well, yeah, and I don't have any attachment to kind of zeroing in on that. I was curious about the different antecedents, but you know what? I 100% appreciate having a collaborative care team. I mean, we just
Mm,
need to, because I mean,
have
and
to.
and you get to be really good as you are in your area. So there's two lines of inquiry that I'm eager to go with you. One is I want to talk about labs, what you're doing. I want to talk about the standard lab panels that you're thinking about in your practice. And I want to talk about, this really cool product that we've been excited to learn about in our clinic, Mira. So so we can go down the lab avenue, or we're going to go down both, or we can start with the intervention avenue. Maybe it makes sense to start with the lab avenues and some of what you're seeing, and then maybe layer in interventions.
Yeah. Yeah. So it's funny because I said earlier, I was like, I don't get why other healthcare providers are just missing this. Because if you pull up like Hippocrates or Up to Date, these tests are spelled out clear as day and they're not being done. So that's where I'm like, there is a huge issue just with the systems itself, I think, and wanting to make some of these diagnoses, or thinking, oh, I'll do an ultrasound on somebody and either catch PCOS or worse, claim they can catch endometriosis, on that, and using imaging and stuff, which you cannot. But for PCOS, I'm doing, your prolactins, your 17-hydroxyprogesterone, DHEAS, insulin, glucose, lipids, CBCs. I'm usually doing iron panels along beside all of that too. They just all, whether it's heavy cycles, hair loss, heat or cold intolerance, you name it, we got to look at that side, and it gets missed all the time too. Androsterone, like I said earlier, testosterone, of course, total free. And then if they come to me and they want to go deeper, I do run, Dutch tests and other tests like that as well. So I
What
will
about
go down that.
thyroid? I'm sure you're looking at
Oh
thyroid.
yeah, thyroid. And it's like, oh, I had a thyroid panel done, it was normal. It's like, no, you did not. I do antibodies all the time. Everyone gets antibodies. Sure enough, there's usually the culprit to the problem. But yeah, free T4, free T3, TSH, doing all of that. I just looked just last week. I was like, okay, show me your chart. They'll pull their chart up on their phones. And like, you did thyroid, and every time they just have a TSH, maybe a T3 done, and that's all they've had done. So I always have to tell my patients too, and would encourage this of others, saying, you know what? I'm so glad that they did something on you. I like to go deeper. Are you willing to let me do my panels on you? And I just leave it at that and try to just, order them, the other things, or redo it if it's been within 6 months. Like I said earlier, I don't do ultrasounds unless they're having actual pelvic pain or irregular bleeding that's not matching up, or, just ruling out other things. What else am I doing? I'm trying to think. I'm usually ordering if we're going fertility and that male's never been checked. There is a home test that I'll do as well, like a yo sperm test on them if they are very hesitant and resistant. Perhaps work, is not allowing them. A lot of farmers or, just men in general, getting them to usually do that is easier. If I'm like, there's a home test you can do, or at that time I'm sending an order to their lab to have it done on them as well, because again, they've probably never had it done. If they've never had a fertility workup, I'll do the FSH, the LH, time it to the cycle, things like that too. And then of course I do always talk about, okay, there's some home kits we can do as well. I'm bringing that in.
How do you time your labs? Just
Yeah, day 3 through 5, if I'm doing, the FSH, the LH, the estradiol. Otherwise, fasting, go in the morning before 10 a.m. and go fasting, because it's sometimes a matter of just getting them in there to do it is the hardest part. And I'm not going to sit and wait around for a cycle.
Yeah, that's right. That makes sense. You just got to get it done.
Yep, exactly.
Absolutely.
They're busy, cortisol stress we're talking. But for cortisol, speaking along that lines, I'm doing a lot of treatment just based on symptoms. And if they really want to know, or I really want to know what's going on, I use like a Dutch test to capture that and see what's going on there.
Give me a quick rundown on symptoms that are going to flag you.
Not sleeping, waking up in the middle of the night, daytime fatigue, if they're just sluggish, not feeling rested when they're waking up, or at any point having daytime fatigue. Neck and shoulder tension is a huge one. Any headaches, usually, aside from the and even if they have migraines, I'm still kind of convinced that that's cortisol too, and I'm bringing in my treatment for that. But a lot of that neck, any joint pain, like, do you have any joint pain, joint swelling, swollen fingers where rings can't come off, sock indentation at the end of the day, that kind of thing as well. Mood. I'm really talking about like mood or irritability. And again, when I'm taking a history, I'm always talking about mental health and like, tell me about high school, tell me about college. And I'm like looking back at that timeline for mental health too, because it goes hand in hand with a lot of these diseases. But cortisol, you'll see that like agitated, moody, kind of anxious, just that daily, high functioning, stressful individual, cortisol.
Yeah, no, that makes sense. All right, let's get over to talk to me about, the home kits. And talk to me about how you're using introduce Mira. Let's get a little background on it. And then how long have you been using it and how has it shifted your practice?
Yeah, so Mira was founded by Sylvia King. She was a scientist and, of course, motivated by her own fertility challenges, what like a lot
Right.
of us.
Yeah.
She faced it herself and her peers and her friends around her, and it led her, thankfully, to creating Mira because she saw too 80% of people with hormone imbalance and 30% of couples getting this unexplained infertility diagnosis, which was me. And it just like I sat there, I was like, this just doesn't make any sense. There's got to be something going on. So
Hmm.
she created it because of people's fertility journeys needing accuracy, peace of mind, and cost. Cost was always like on the forefront of the creation of this device, too. I
Where,
use it
let me
for
just ask you, save that where you use it. Is she here in the States?
in California.
Is she? And it's
I think
interesting.
so.
Maybe we'll link about her. We'll link to
Yeah.
her background because I'm super curious, like, what her
Yeah.
focus is, what her PhD is, but fascinating. So
Mhm.
she had her own struggle.
Yep, had
Amazing.
her own struggle
And
and
then
saw a lot around her, especially with PCOS. That's the main diagnostic factor that kind of drove this because it's so hard for individuals with PCOS to just use these over the counter,
yeah,
take a picture, device type of thing. It's not effective. The other really cool thing too is I know they're expanding their machine to include other things. So we're going to be able to see cortisol,
that's
testosterone,
so cool.
ketones, all sorts of other general health stuff coming too. So it's a really, that's kind of what got me into it too. I was like, okay, you're not going to just use this during your fertility phase. It can be used into menopause and for other aspects of our life too, instead of just this blip in time as well.
And what
Uh,
is it? What is Mira? What's it? And you
yeah.
don't happen to have it? I mean, I know
I
it's
mean, mine's literally in my bathroom at home because I've been using it. I should have brought it. I don't have any in clinic here. But yeah, it looks like a little egg. It's like a little egg, little circular egg, and it comes with this fantastic, everyone's like, what do I pee into? Do I get a plastic container from under the, cupboard? No, it comes with a nice little cup and these easy to use sticks. And I always tell my patients, I'm like, okay, I'm going to add you. We'll talk about this too, the back end portal. But I'm like, I get to be in the bathroom with you. That sounds really, usually the lighthearted ones. I'm like, this sounds really creepy, but like I'm in the bathroom. You just tell me whenever you want me to look at your chart, and I'll be in the bathroom with, checking your hormones
it's
right
super
beside
funny.
you. But I just, roll out of bed. I leave mine on the counter, lay everything out the night before, and it's just super easy to use. But it's like really true quantitative technology too. And like this, fancy lab technology, it's palm size. People travel with them, but you get that lab accuracy at home and you don't have to go in and get blood draws. And every body BODY is so different that you can't just, okay, day 21, come in and do that. And not everyone wants to be doing the expensive fancy testing too. We need something cheaper, a low hanging fruit that they can enter into and use FSA and HSA money and all that stuff too.
That's awesome. So it's this little egg, and the reason you don't have them in practice is because they're just drop shipped directly
Yeah, they're drop
to the
shipped
patient.
directly. Yep.
Yeah, so you don't need
Yep.
to stock them.
Nope.
But it's this little egg at home. They pee on their little dip and then pop it in
Yep.
the egg, and then you get the data
Yep.
and you have it presented to you as we would read it as clinicians. What are the analytes that Mira's looking at right now? What are the analytes on there?
Yeah, so FSH, LH, progesterone, estrogen, and you can even link basal body temperature devices to it as well.
Oh, cool.
So it's really a great, full full stick. One stick can get all of that. It's not doing, you're not in there doing multiple sticks. One stick can do that. And then if you want to save them money, they do have some different options. Like, for example, you can do just a progesterone stick as well. So sometimes I'll tell my patients, okay, once we see this happen, we can move into just that progesterone if you want to save some money too with that.
Do you think they'll hook it up with wearables? Like, speaking about cortisol, like having
Yeah,
HRV data, and beyond basal body temperature. I mean, actually, this does have some temperature data, but it has like pulse ox and obviously my sleep data. God, that would be
that'd be
fascinating.
so awesome. I'm
Hint,
here for
hint,
that.
Murray,
Come on, Sylvia, you
Mira.
can do it.
That would be super, really interesting. I mean, you could like
Yeah.
publish, you could publish on your observations, seeing the sleep connection and,
Oh,
that's
absolutely.
really interesting. Okay,
Hmm.
so you're using the Mira with some of your patients. Like who's the ideal patient? Obviously, we're talking about PCOS, but what kind of data are you able to pull? And then how does that guide your interventions? And let's talk a little bit
Yeah.
about your approach.
If I had a magic wand, I would tell women to do this before, if you want to get really, really into it, before you even, I don't care if you're not even dating somebody. If you just want to know about your health,
Yes.
I would love to have teens do it. Maybe, especially if they're coming in with signs. You're going to see some of this stuff happening on the back end,
Yes.
hormones, and she's moody during this time. Let's see what her estrogen's doing. Let's see what her progesterone's doing. Is it cliff diving? Is the day she's just just a snotty teenager,
Yeah.
is that when she's having these,
Yeah.
cliff dives, as I call it? Like, there's a reason people are
Yes.
feeling that way.
Amen.
um EMDD, gosh, we could catch so many things, with that
Yes.
too. And just, is there something going on hormonally during that time? Like, if you're just
Yes.
wondering if there's something hormonal, aside from all the other reasons for mental health and other symptoms, but is there a hormone correlation going on? I really want to encourage women and to really get a hold of any concerns they have before they meet their true love. Because usually when maybe you're engaged. So I even set up my clinic, vendor show one time at a bridal show, because I'm thinking, women need to be thinking about if they want to start a family or they have concerning, whether they realize it or not. Just a general preconception workup should be on the forefront of mind, because we don't want to wait till you're ready and then find it. And now it's taking months and months for you and maybe even him to have things resolved. And so it's really just the earlier the better. There's no wrong time, I think, to kind of know what's going on with your.
How early could a girl start using it? Like if she's getting, I mean, we see these changes, particularly the emotional changes happening in girls before their period starts. And of course, periods are getting, we're seeing more and more precocious puberty. Would this be something that could be useful in that arena?
I do believe so. Yes. I think it could give us some insight into, are they flatlining with their hormones? Like, did they really cycle? Are they cycling and just not bleeding? Are they having peaks in LH and estrogen and things like that going on too? And then it's like fun, because I was like, oh, your mom can use it too. Like, they can both use these devices at home too
Yeah,
together. It can be something that we're doing together,
cool.
as a mother-daughter, to figure out what is going on. There's a why. There's a why to things. If you're not smooth sailing, I hardly know I have a period, I get it every month at the same time, life's fantastic. I'm feeling great all the time. If that's you, you can maybe wait a little bit. But if you have any if you do not feel well, and you're concerned and you're not getting answers, there's nothing, it's not your thyroid, it's, you don't have anemia, everything else has been kind of ruled out. This is an easy thing that you have the power in your own home to do and utilize.
Really interesting. So cool. So cool. All right, so let's talk about some of the interventions that you're using. Maybe let's start with PCOS or just some of the treatment
Yeah.
approach, and then let's touch on endometriosis as well.
Yeah, so for PCOS, of course, and for all of them, I'll just start with what I do for all of them. I'm looking at lifestyle, sleep. If they're not sleeping, why? and really making sure, dark room, sound machine, cool temperatures, checking melatonin levels, if I have to. I'll get into my unicorn dust, as I call it, here in a second. I'm looking at nutrition. Are they eating enough? Because we know too from studies, 1,200 calories or less can really be harmful to hormones too. I've even switched to say, hey, are you taking a bite or a drink, of your protein and your fiber first, and how when they are eating, changing the order of their food and really optimizing their levels of insulin and glucose. What are they doing for activity? Are they so tired they can't even get off that couch? Like they're crashing, then I'm looking at cortisol care that I do as well. I'm teaching them how to meal prep, how to plan. I just brought in a service that delivers it to my door lately because I myself am not eating enough. Are you like fasting all day and it's backfiring? Really revamping things. Again, growing the team. If they need to have a nutritionist or dietitian or some other specialty come in to help with that, or doing that. Do they need a personal trainer? That kind of thing too. I hate saying the word stress because I'm just like, it's cortisol and it's life, but like, what are areas in your life that you can change or adjust? Like, are you at this awful job that you've been at with night shifts and shift changes and for 10 years, and you do have an option to switch because shift work goes negatively towards fertility? We know that from studies too, for men and women.
Sure.
But shift work can greatly impact that. What are external factors that can be fixed? Do we need to add counseling and therapy as well? Hypnosis. I love hypnosis, meditations, things like that into our daily routine as well. Environmental stuff, products that they're using, and really reviewing that as well. Are using plastic still? What are you even reheating your stuff up in the microwave? I still always talk about that basic stuff too, because it gets forgotten about.
Sure.
And then I love, love, love. I started to really use low dose naltrexone in my practice. And it has been instrumental. I take it myself too, to really, help with that cortisol drop. But there's a lot coming out on fertility with that and general inflammation in the body and it helping with that. And then of course, getting them set up with supplements, the myo-inositols, NAC, berberine, maca, and then the herbals. I usually have I offer acupuncture. It's really cool. A lot of people a lot of acupuncturists are even implementing Mira into their practice because they can time acupuncture based on levels and things like that too. So I'm always growing their team. Do you want a cold plunge? And that's like the latest thing right now, and infrared saunas and acupuncture and other fun things like that too. Gut health. It's not me, but let's grow your team right now and let's figure that out. If you have those symptoms, it's really working on all of those symptoms they're having as well and bringing in outside resources. And getting them to eat more too is just something very basic, and looking at that, what does their plate look like when they're eating? And I'm asking, tell me about your day, tell me about a daily intake for you and things like that as well. And then I like to, what format of supplement are they taking? Are they like choking on 6 pills a day or 10 pills a day and saying, I'm like, we can get this in the powder format, or, that, and really working with, maybe they already have implemented something and it's not working. We can kind of adapt and shift, don't quit it altogether and give up on things. It's like, what else can we do to optimize, great supplements and other things too, if they're not liking what they're doing?
I mean, you're using hormones in this population, I would assume. Like, do you want to speak to that in PCOS? I mean,
Yeah, really.
progesterone,
So
yeah. Mm-hmm.
yeah, the only things, so for fertility, sometimes I will use ovulation induction medications like your
Mm-hmm.
Femara, letrozole. I go to that first before going to Clomid. It's better on estrogen levels and side effect wise. And then if we're doing IUI, we're doing the trigger shot, things like that as well. Progesterone is something that gets forgotten too. It's such an easy, if they want a baby yesterday, and we're doing all the other things to naturally try to support their hormones and progesterone, I will bring in, what I try to do is oral progesterone 3 days post ovulation, or when I see the Mira fertility kit, kind of peek and show me that they've ovulated or they're about to ovulate. Bring in that day through post ovulation day 3 oral progesterone, and then at time of conception I will bring in suppositories. A lot of people are just like complaining about the ooey gooey goopiness of it, and that kind of thing. Sometimes I'll bring in suppositories as well. A lot of my patients I'm finding have PMDD, premenstrual dysphoric disorder, that's missed all the darn time. And I've really shifted to troche progesterone for that. So a lot of them are on it during that phase and that time anyway. So it's helping that progesterone for, conception and things as well. And then supporting it too with supplements. My patients walk fish oils, vitamin D. Are they deficient in their B vitamins, and looking at some deficiencies as well that they might have going on alongside supporting the PCOS, just really supporting their general minerals and other things like that too that they might be deficient in naturally.
Unicorn dust. Is that LDN?
That's my LDN, my low dose naltrexone. LDNresearchtrust.org is such an amazing website on it. I don't know why some providers are so scared to use it, but really work with the pharmacy, a compound pharmacy that like is skilled on it. And I am very, very lucky that pharmacy I use has a tracking system. They track patients' symptoms, they follow up with them, they check on them, they help dose it. They really make it easy to use. And really hands off as a provider to kind of, they help take care of any side effects, which are usually minimal in patients. Usually what we're treating with a dose change will get worse, a headache, joint pain, fatigue gets worse. Within the next day, you drop it back down to previous dose and they're doing well on it. So it's really underutilized and can just like, you'll be the hometown hero. If you start using that stuff.
That's great. That's great to know. And who's your compounder? Are they local
Yeah.
or are they national?
It's called Erskfield Pharmacy. They do other states as well, but they are the ones with the tracking program in place and really hit it. Patients they're like, how is a pharmacy so nice? Like they care about me too. Again, that growing your team includes a pharmacy in my practice, and it really, they just have next level care, too. That's hard to beat. They do mail to other states though too.
And you're focused on fertility in your practice, but like, are you working, are people coming to you on birth control, and are you having to taper them? I just want you to talk a little bit about that journey, because that, in PCOS can be, tough.
Definitely. So I do. There's a big, trend of that. People wanting off, they want off. And what I will do is, because it's really limited what you can draw to some extent when they're on hormone replacement. You can't do a lot of testing. That's where tapping their high school, college, pre-birth control timeline to figure out, is this endo? Is it PCOS? Now, a lot of things can overlap. You'll have your good herbals that can really help with both, but I will put people on myo-inositol, NAC for sure, maybe some magnesium, even I'll put them on stuff. And I'm like, okay, give me probably 2 to 3 months on this before we take it off, if you can, and then let's take it off. They do so much better with symptoms and stuff.
When you stop ICP.
LDN, I'll even bring in low dose naltrexone, the
before
supplements
you stop them.
Before stopping it, and you will have much better results. And unless they, of course, they wanted it out yesterday, they're done with it, or they stopped it already. I'm like, okay, just give me 90 days at least. Like really commit up front. Like this is going to take a little bit of time. Hirsutism is so slow. Hair loss is so slow to come back. I think when implementing things, it's not this like quick fix, like the mood, like the anxiety that will go away like this with within days of starting low dose naltrexone. I will also wean SSRIs a lot in my practice with utilizing low dose naltrexone, of course, hormone balancing and figuring out whys too. Well, you can very easily, again, every case is individual, but with support of, if the counselors and other professionals on hand too, and having good systems in your practice, you can wean people off of other medications, chronic pain meds, all sorts of things too, when you bring in and fix that cortisol issue.
Dr. Kelly Brogan once, many years ago advised using liquid SSRIs for the taper, so, and
Oh,
yeah, so that you could just really do a micro taper.
yep.
Because that
Those are
can,
hard.
yeah,
They're
they
hard.
can be really, really hard. Yeah. Um, what else did I want to say about this? It's fascinating. Okay, so somebody's on OCPs, they've been on for a long time. Maybe they were prescribed when they were, as soon as they had, a difficult menstrual cycle,
Mhm.
like from 12.
Yep.
And I mean, what are we looking at for the fertility journey with long-term OCP? Does it always have to be difficult? I mean, what are your thoughts on that?
No, it doesn't have to be. And, especially like the PCOS ones are maybe I would say a little bit easier. I don't know if that's even the right word to say, but like if they're on that and they weren't ovulating and you pull them off, so in my practice that I will see some months of a good cycle and then it tapers off 2, 3 months, 4 months, 5 months of a oh good cycle, you ovulate, good cycle, you ovulate, and then it tapers off if you don't bring something else in or they've already done that data collection up front. Like I came off and I was doing good. And now look, there's nothing, they've kind of captured that themselves for you to see. And then, you need to target things that will induce ovulation and bring ovulation back. And I think another thing that goes missed all the time is insulin resistance. We are not checking for that enough and treating it enough. And I will say in my practice, I have started to use some injectables in this case because when I've run every test, including, every test under the sun, and I'm implementing everything, and there's a team approach to this, and I can't get that insulin to move, and they are not getting a period. When I bring in the semaglutides, the tirzepatides, they are starting to cycle. Mucus is coming back. I'm getting androgens are dropping, levels are dropping, Hirschism, everything is dropping. But I'm talking on day one, our exit strategy. This isn't, we're not doing this for life. We're going to get this so that that 50-pound weight that's preventing you from eating and cooking and exercising goes away. And then we can taper our dose or decrease it or get you ovulating, get fertility and get other things working. I call it like unsludging or getting them unstuck. And then, talking about weaning that off. So it is kind of I don't know, an interesting thing I found in my practice is like I'm doing everything, and this woman is not getting like I'm talking 90 to 100 days of no period, and I bring that in, and it's like we're getting a period and cervical mucus and ovulating. It's
Wow.
hard to not want to, go that way for a little bit too,
Sure.
and help these people out so they don't need IVF and they don't need IUIs and things like that too
Wow.
if they're willing. And I keep a close eye on them. They're in my office every 6 to 8 weeks. We're doing lab work. This isn't like a med spa where you're just getting your shot for high dollar. It's a program that they have to enroll in, and we make, have a lot of firm things put in place to make sure that they are getting checked and coming back in and things like that too.
And what are some of the other, and then I know we have to wrap up, but you're just jogging a lot of questions in my head. This is such a great conversation, but like what are some of the pre GLP-1s interventions you might do to stoke ovulation? In addition to
Yeah.
the lifestyle and the supplements you've already talked about, is there anything else you're using?
Walking. Oh my gosh, if I can just get these people even walking after their meals or just walking
Sure.
during the day is huge for that. You'll see that feel good and the insulin. There's some studies that came out too on movement, even if it's just for 10, 15 minutes when, after eating that meal or changing, like I said a little bit earlier, the order, putting fiber and protein in your mouth first. And then, don't eat the whole chicken breast or don't eat the whole serving of veggies, but just flipping a few bites. There's data coming out on that too, showing to be really effective for insulin resistance. But the other thing when you start those GLPs is, the biggest thing is the constipation, and patients are just, they don't want to stop or adjust their dose because they're getting good results, but they have this. And so it's really honing them in and be like, I cannot have you constipated. So it's really tracking those symptoms and working with that. There's aloe juice and probiotic, prebiotic, making sure they're on all of the gut stuff too, going into it or tracking them and not letting the side effects and symptoms get out of control when they're on those medications too. And then I always like, okay, what's our goal? Is our goal weight number and a feel good, or you're going to the gym now, or you're walking more, or you're doing this? Like, what are the goals that we're going to start weaning at and cutting back on this at too? Um, and it's of course, you know, a needle issue too that some have too if they don't want that, but it good old insurance is getting teensy bit better about coverage with this too, if we do our good old prior authorizations and stuff like that, to where these individuals are, you know, candidates for it. And again, talking about exit strategy on entry strategy, but just knowing that it is an option and it's really helping with fertility.
Yeah. Well, listen, Dr. Harding, it was just great to meet you and to hear about the good work that you're doing, both in your own journey and, you know, what you've brought forward in the world of infertility. I mean, from your nonprofit to your current clinical practice to your TikTok rock star status.
Yeah, we'll have some fun with that.
Which you guys, she told me was almost entirely random and happy. It's kind of a funny story, but we'll link to as much as we can so people can track this down. But really, you've given us a lot of just incredibly useful information, and we're thrilled about the advent of Mira, and it's really nice to see with your years of experience with it how useful it's been for you.
Yeah, thank you for having me. And it's super helpful. It makes it so easy. You just go onto your provider portal in the back end and you're in the bathroom with them. Like I say, there it is. Boom. There you are.
That should be their tagline. We're in the
Yeah,
bathroom with
I
you.
know. I'm like with you. And I have such a, joking, I have such a good connection with my patients too, that of course it's a funny thing, but it's like, yeah, like it's how cool it is. You can be right there beside them.
Yeah. Yeah. All right, my dear. Well, thank you so much for
Thank
joining me.
you.
To be
Yeah.
continued. Ciao,
Yeah.
ciao.